Hello everybody, and welcome to this week's edition of Inside Implant Studio webinar. We're live here from Copenhagen, Denmark, and we're excited to spend the next 30 minutes approximately with you guys. Today we're going to talk a little bit about some basic considerations of how to place an implant. The reason that we think this is relevant is, of course, when we go out and talk to dental professionals, we get to speak to you guys out there. Then we, of course, receive a lot of questions on our products and what it is that going digital means for implant dentistry. But we actually also often end up discussing some clinical considerations with you guys and with users and potential new users. So these are some of the considerations that we've tried to gather here today that we want to share. As always, you're more than welcome to ask questions. We will be monitoring the questions coming in the chat and in the question here on the webinar. So ask questions, and then we will either answer them as we go along if it fits in with the program, or we will answer them afterwards. So today, here is me, myself. My name is Thomas. I'm a product manager working with our different implant products, and especially the Implant Studio here in 3Shape. And then I have my colleague Jan, who will take you through the today's agenda.
Welcome everybody, and as you notice, it's Thomas by my side today. We thought we should mix it up a little bit. And Thomas also has some new insights in how we can do this. So very welcome, Thomas.
Thank you.
So we have some questions on the agenda today. We would like to talk about how to select the right implant when doing implant planning, how to place the implant correctly, and finally how to place them so we can distribute the forces from the mouth and from chewing. Remember that this is mostly for non-surgeons, because as a surgeon you know already these three items, but it's sometimes good to actually go back and rehearse again, or to just see it from another surgeon's point of view. Again, this is not a manual, and all planning that you are doing, either as a referral or as a laboratory or a colleague, you have to get approved by the actual surgeon doing the surgery. So the responsibility is always in the surgeon's hands. Also, some of the images that we are using today come from other places than 3Shape, so we have marked them with the respectively brand where they come from. So welcome again to basic considerations. So let's see, let's go to the next page. We would like to start with how to select the correct implant, and then I would like to discuss if we should use bone or tissue level, and then finally if we should use straight or anatomical implants. The goal, the overall goal is to see to that the implant actually is covered with enough bone on all sides. And this is important so we can ensure stability and also a good osseointegration. So let's start with the length and sizes. Implants, they come in many variations. They come short, long, fat, slim, groovy, machined, and so on. And most of you out there already know this. But why do we choose the ones that we are using today, and why did we change from the ones that we actually used 2 weeks ago? Sometimes there is fashion in which implant to use, and sometimes we read something in an article and actually change our knowledge base. So the selection of implants can come from different places, and I will try to cover them all. So let's see. The length of the implant can of course be decided on how close we are to, for example, the nerve. If I show with the pointer here, we have the node, we have the foramen mentale down here, and then we have the mandibular nerve. And of course, if we use short implants, we are safe. They are not near the nerve. But this can also be a good way to use for example, if you are uncertain if these will osseointegrate perfectly. It's easier to remove a short implant and then actually replace it later on with another. If you have a long implant, you have to drill it out and you will destroy more of the bone. That's one idea from the manufacturers. The other is actually that when using short and fat or thick implants, you can actually acquire the same stability as if you are using a long and the normal sized implant. So two different schools here, and you have to ask your referral or your surgeon which implant system he actually prefers. We have the long implants, and as you can see, in the beginning of the implant history, we tried to place them bicortical. So one attachment in the upper level of the bone and one in the lower as low as possible. So the implants could be 16, 18, 90 millimeters long, just to ensure primary stability. Today we have learned that we can get this stability even with also with shorter implants and with different kinds of threads and surfaces.
So I guess it's interesting that there's multiple ways to obtain stability with different shapes implants. I mean, we've learned that now that the overall surface area of the implant is important, the thread is important, the cut is important, and this all plays into how stable the implant will be placed.
Yes, as a surgeon, you often look for a primary stability, so you know that the implant is steady in the site, and then you can expect some healing. Because after healing, after 2 weeks approximately, the implant becomes looser again, and then osseointegrates for real after 4 to 8 weeks or something like that, depending on system, of course. So manufacturers can say that, okay, if I have this roughness or this groove or this surface, I can expect osseointegration and primary stability after 2-3 weeks, and others say after 5 weeks. So there is a big variation and a big difference among the different manufacturers. What we see here is also the question if should I go tissue level, actually having the implant penetrating the soft tissue, as we see on the left here. These are Straumann implants, and they are the first ones, or actually the biggest ones in the tissue level implants. And if the implant penetrates the tissue, of course we can expect very good healing in this area. But we have also from the same company bone level implants, which actually is covered by the soft tissue during healing, and then you will penetrate the tissue and place an abutment in the same position. So which way to go? What is to prefer? And sometimes it's actually the surgeon's favorite that will decide which way to go. But also things like, should I use screw retained or cemented? Where do I want to place my cement gap? Today we know that there is a lot of discussion going on if actually the cement gap and the cement itself is the cause of many implantitis and implant failures. And maybe this is why we don't see them so often on the Straumann tissue level as on other implants which are bone level. So yeah.
So you get to travel a lot, I know, Jan, and talk with dentists from and surgeons and also dental labs from all over the world. What is the trend these days? Is it possible to say anything about more implants moving in the direction being placed as bone level implants, or does it depend on experience, preference mostly locally?
One easy way to call it is to say that if you are trained by a company that uses soft or tissue level implants, then you prefer that because you feel safe and you know what to expect, and vice versa. But what I really can recognize today is that first we see a trend that we are going away from cemented constructions, so we're actually going more to screw retention again, and also a trend that in the distal areas we use more tissue level because the soft tissue is thinner and it's harder to actually work with. So placing an implant that actually penetrates the soft tissue already directly after surgery is to prefer. But in the front, where we need good aesthetics, where we need to cover the implant and get a nice emergence profile from the implant and up, we see more bone level implants. So there's actually a distinction on where in the mouth the implants are placed. So if we go and look at one more factor that actually comes into consideration, it's should I use straight implants or anatomical implants or conical implants? Again, the quality of bone can decide here and help us which one to use. Is the bone hard or soft? Hard like in the lower and softer like in the upper jaw. Do I place my implant immediately after extraction as an immediate placement? And again, the surgeon's favorite comes into play. And of course, sometimes also fashion. It's like with clothes. When one manufacturer starts producing a conical, other ones want to get into the same area because they don't want to lose market share. So sometimes it's fashion. So if we look at this, we have the straight implant to the left, and then we have the conical or anatomical implant to the right. Anatomical, as you can see on the right side, that it actually resembles the root of the normal tooth of the tooth. So here the man is trying to assimilate or resemble the normal anatomy of the tooth. On the other hand, with a straight implant, for example, in a newly extracted tooth, we can see how the threads actually grip into the bone in another way. So again, depending on the bone quality, fashion, the surgeon's favorite, both are as good, especially in this position. If we look at the next area is actually how and where should we place the implants. So here I want to show you a little bit about what to watch out for, how the distance to teeth and to other implants should be. If we angulate the implant, what to look out for there, and also some anatomical structures that we can have to recognize on the x-rays and to be aware of so we don't get any accidents. The overall goal here is to have at least 2 millimeters of bone in all directions. So that's a way to start, and then it's up to the surgeon or the surgeon that actually approves the planning if you want to go lower on this amount. But 2 millimeters gives enough with blood vessels and tissue for the bone to heal well and to give a perfect osseointegration. So for example, we have these two again. We can see on the left side that there is enough space. The implant is placed like if it was another root on a tooth, and it actually keeps the place of the original tooth, the second premolar that was placed in this position before. The same with the conical. Enough space for both sides. we're going to get back to this area in the top where we have the sinus to give you a little bit more information about that one.
So this is actually interesting that now we've talked a little bit about the shape and size of different implants, and merging that with the position consideration. Then you can say that when you plan your implant treatments, you actually both need to consider, of course, what room do I have available, where do I have bone, but I also need to hold that up against, am I placing short versus long, am I placing a conical versus a
straight
implant.
Yes.
And there's a lot of variables in play here where of course digital tools will help you build a workflow and build a routine, you can say, to arrive at the right decisions.
And the knowledge and the understanding from the surgeon really comes into play here, because if you are well trained and you have the knowledge, you can see all the problem areas and you know which implant to choose and where to go. But for example, if you are having your laboratory do your planning, like it's very common today, the laboratory has to have this this knowledge, and this is not a common area in lab school to learn how to place implants. So first, this is why we do this seminar or webinar today, and actually I think that the laboratories doing this for the dentist should actually sit down and talk about this. Maybe use this webinar as a planning tool and educational tool, and to sit down and discuss with the doctors to get the best possible planning for them.
Good point.
Here I want to show you some errors that easily can occur, and maybe you guess already, but this is not done with any planning tool or with a surgical guide. This webinar is a part of the Implant Studio, Inside Implant Studio series. So of course normally we talk about planned surgery and guided surgery, but this is what can happen if you are, even if you are skilled, this might happen anyway. So on the left side we see an implant that actually slipped in too close to a vital tooth, giving problems with the nerves and the arteries, so necrosis of the tooth and problems with the periodontal area as well. Here we have enough space in between, but then between the two next ones it's too tight again. It's no 2 millimeters here. In the middle picture we can see that we tried, or they tried, to squeeze in 2 implants. A bit afraid of the canine over here, so wanted to go away far, not to hit the tooth, but by so actually not giving room enough for the second implant. So again, with planning we would have seen this, and the guide would have helped us to place the implant at a perfect distance to the canine. Instead now we are crowded into this small area. Finally, the third picture. Here we can see, and if you look really close, you can see that there is absolutely no bone in between the 2 implants. They are so close together, so nature could not establish a growth of bone or osseointegration in this place. So the only area that the implants are fixated in is the apical area, and as it looks, this might of course be a infraction from the X-ray image. Sometimes we can see these black and white areas, but it looks like this osseointegration is going away here as well. So a failure is imminent, and again very close to the apical part of the incisor. So if there is no bone in between, we don't reach our first main goal, to have bone surrounding the full implant. So this is most certainly a failure.
Interesting that the human body almost knows that the goal is 2 millimeters in all directions, and if not succeeded by the surgeon, then this is what will happen. Yeah, that's...
We have a good map we have the nature itself with the teeth, how they are positioned and everything. So if we look at them and try to emulate the same variables with positioning, with length, with the directions and forces, then we are more likely to succeed than otherwise. So this takes us into the angles, and you know our two friends here again. And what we like to talk about regarding angles and directions is actually that try to follow the original teeth. If they are positioned in one way, try to place the implant in the same way. Don't try to steer away from nature trying to find the position. Of course, if there is no bone, if you need to place it in one position because it's too tight between the two teeth for the crown, then you have to do side steps and you have to find another solution. But if there is room, always follow nature because it's done once, very good, and we can maybe do it once again as good.
So follow nature, yeah, and that, does that mean follow the direction of the root that used to be there of the tooth and the natural tooth as well? So you kind of combine, you can see what's behind or below tissue level and what's above tissue level, or is it always let one or the other thing steer you?
When looking at these two implants, we can see that the surgeon here actually followed the rules very good. He tried to, or she tried to mimic here the length of the root. So the length of the implant is the same as the actual root, and the crown is not bigger than the actual crown, or in the same area at least. This means that the momentum that can occur, let's see here, we got out of this, let's go back. The momentum that can occur if the crown is too big or the implant is too short, that actually it will be a tension to it, so it rotates out of the bone, will not occur. So following the nature gives more stability and more predictability as well. We see also on the second image to the right, same size, same length, and same crown as the original. Very nice and very professional as well. But what can happen if we do it wrong? Well, here, if we see the green lines, this is still the direction and the angle of the original teeth, and suddenly we have the implant in the different direction. Is this due to the problem to navigate in the mouth? Because when we open up a flap in this area, we think that the angulation of the jaw is actually different, so you have to compensate for that when you do surgery. An experienced surgeon knows this, but if it's the 5th or 10th implant, you are still a bit nervous and you focus on placing the implant in the middle, but you miss the angle of the actual teeth. It can also be a case of a punch technique where you actually do flapless, so you didn't see where there actually other roots were underneath the tissue. Problem can be many, but the problem here is actually that the implant was set in the wrong angle. So problem with the crown later on, and also with hygiene in some areas possible. So a lot of things can go wrong.
And I think it's interesting because I've had that experience when talking to dental labs, you know, not to point fingers at any surgeons out there, but they all say we have tried to restore implants like this. And if the angulation is just too much off, then, I mean, we can try our best in the lab to restore it, but at the end of the day, then we know that the restoration that we will be delivering is not going to last as long, or it's going to be hard to maintain, or so I think this is a really, really important point, and seeing this picture is, it makes it quite clear, at least to me, who's not you know, trained and doing implant planning or surgery as a living.
But you are, as the director and manager of Implant Studio, you are of course well trained in the software and you know everything. But now when seeing this, it could actually be a nice tool, or actually to aim for to place the implant in the same angles as the original teeth if we have them.
Oh, absolutely. I think it, you know, using existing anatomy that's present in our beautiful 3D CT scans coming in, that's definitely an area where we could say you could mark up things during your diagnosis, and if we could then even adjust that with some smart helping features to make the planning safer and even easier, then I think that's something we will be looking into.
Mm. But this is one implant. What happens if we have more? Well, like here, we have implants, 6 of them in the upper jaw and 5 in the lower. This is a very nice distribution of the implants and also the placement. But then you think, okay, this looks straight and it follows the teeth, but these up here, they actually look angulated, and shouldn't we follow the normal tooth or the normal teeth? Well, if we put some colors on here, we can see that they are actually placed in the same position as the normal teeth. But the image, as this is a panoramic image, it actually curves or distorts the image a little bit. So in the mouth, when we do the surgery, this is a straight line. So this is a very nice example of how you can both place them vertical to the bone, perpendicular, and this gives the implant the best possible site or place to osseointegrate, and also then later to actually hold the bridge. An important thing here when we place the implants is that we try to distribute the implants that we're having on the full area of the bridge. I will later show you some examples where they are placed too tight, and that also can give problems of another kind. But let me come back to that later on. That was the angles and the directions of the implants. But I also wanted to show you a little bit what happens if we come too close to anatomical structures that we have in the face, in the mouth. So, for example, on the right here, we see a frontal image, like looking at the person. We see the eyes up here. We see the nose cavity. We see the teeth, the 2 arches, and we see the 2 sinuses. One is empty, as it should be, and one is filled, probably because of a cold or some other problem, maybe a dental problem causing this. We don't know. So in this area we want to place an implant, and if we look at the left image, we can see that if we have sufficient bone, it's easy to place the implant and there is room enough. But as we get older, or the sinus disforms or actually reshapes as it does over age, and also if you lose your teeth, it will reshape. And why is that? Well, nature is so fantastic. So the sinuses, we think, is there to actually reduce weight in the skull, and also to give us good acoustic features, so we can sound nice when we talk and sing, but also to actually not have extra weight where not needed. So if there is no teeth, like in the middle illustration, the sinus will actually grow and will eat up this bone inside to fill it out with the cavity instead. So when we place the implant here, if we don't look up, it's easy to actually end up inside the sinus. And what happens then? Well, what we know is that if we have unsupported or not bone-covered implant, that increases the risk for failure. So again, back to the main goal, cover the whole implant surface with bone, increases the chance for success. So let me show you some examples here. Our famous Straumann's again. Here we have the implant. It looks nice, but according to the white arrows, we can actually see the surface or the floor in the sinus, meaning that the implant actually is looking up into the sinus. If we have an implant that is rounded and nice like this, we can expect that the sinus tissue inside actually will be lifted up like a tent with a pole. But we never know, because before placing the implant we actually used a very sharp burr, so we don't know what happened.
So we could, yeah, punch that.
Yeah, of course, when we plan and we know that we will penetrate this area and go into the sinus or to the nose cavity or somewhere else, we can plan accordingly. We can stop drilling just before. We can punch it up or lift it up with osteotomy tools, or to actually open up a lateral window into the sinus and make a graft inside where we place the implant. So we have many ways to do this. But if we don't see this, if we don't have the CBCT with the planning tool and the exact positioning in depth of the implant thanks to our guide, then we can actually end up inside the sinus or the nose cavity. So down here we see it even more, how the implant actually is rising up quite a bit inside the sinus.
So I think I participated in one of your trainings some time ago, yeah, and one of the things you mentioned there is, I mean, where there's no bone, there will never be bone, unless we do something to overcome it. And of course you mentioned grafting and different lifting techniques of the sinus. But really it's important that if there's no bone when we place the implant there, nature will not do magic.
No. So bone don't walk and sit down on the implant. The implant has to be placed inside the bone.
Yeah.
We are trying today by placing grafts and membranes covering implants, and trying different techniques in the sinus by osteotomy, for example. When we lift the membrane, it actually fills up with blood and we can see bone growth inside that area. But just placing it somewhere and expecting bone to grow on top of it, no, that will never happen. So when we look at the other side of the mouth, in the lower jaw instead, we have something that actually terrifies most of us until you know where it is. So when we look at a tooth area with the mandibular bone, we can see that there is a nerve inside the bone. And what happens when we take the tooth away, because that is why we place the implant, because there is no tooth. So the tooth is removed or lost, and then again, to reduce weight in the skull and also to remove bone that is not needed, nature will deform and absorb the bone that is on top, putting the rooftop of the mandibular closer and closer to the nerve. So we can see it doesn't change from below, it actually resorbs from the top down. If you place a prosthesis or a partial denture on this, it will resorb even faster. The only way to actually keep it for a while is to place an implant. But what happens if we place an implant in this area? Let me see if I can find the cursor. So we have the tooth, we have some resorption. Again, here we have the tooth, the bone level is high, so we think, okay, we are going to have a 12 millimeter implant, because this is the length here, that we want to use and place. And now when we come to the area where there has been resorption, we place our 12 millimeter and boom, we might actually go into the nerve or put pressure on the nerve. Sometimes you don't need to go into the nerve, only the proximity to the nerve, actually the bone being heated up by the drill, or the forces expanding the bone in that area when placing the implant, can give cause to sensitivity problems in that area.
So I guess this also means that restoring or replacing removable prosthetics with implant prosthetics in patients that has had removable a partial denture or a full denture or something like that for many years, that then this becomes a practical problem that needs to be solved by the surgeon.
Yes, Most of the cases we see is that patients come in with partial dentures that they have been wearing for a lot of years, and they have been relined and rebased so they will fit properly, but every 1 or 2 years they have to reline it again because it's sinking. And that is due to the resorption. And when they come after 10, 15, 20 years, because they don't hold out any longer, because they don't want this problem every second year, they ask for implants, and then we have this problem. It's too narrow already. So the best thing is to not go to partials, but actually to place the implants as soon as possible. When we think about keeping the bone, but then there are other perspectives we have to oblige there too as well. So let's see a full panoramic on this, like the same way. We see here we have resorption in the side. We see the residue bite from premolar to premolar, very common. And finally we decide to place implants at the back, so we don't have to use the RPD anymore. And then we place the implants and we place them too deep. So what happens, we actually go in and we damage the root on the right side, and on the left side we are so close, so we actually got some problems here as well. So this is common in the area where you don't know the bone, you don't know the quality, the size, volume, because you didn't do planning. And when you did planning, you didn't use the guide, so the implants could actually end up in some other place, even if you did just the planning part. So of course, talking today about Implant Studio and the possibilities and predictability with Implant Studio, it says itself. Here you should have used a guide instead. Even if it looks simple, the problems can be big, and then it's wasted time and money. So we have one part left, and it's actually how we should place the implants for the best power absorption, how to place them to be able to receive and work with all the forces that we get from the teeth when we are eating. How many implants we should use, and if we should angulate them or keep them straight. And of course, as a good listener, you already know that this angulations part, you know the answer there, but let me take it anyway. So the main goal here is to spread the footprint of the bridge or the implants to as a big area as possible, to spread also the forces over that big area. So we come back to our image. We spread the implants over the full area if possible, if there is bone enough, if the nerve isn't too high, if we have a guide that can help us place the implants, and we dare to place them in the posterior areas. This is a perfect distribution of the implants, and later on also of the forces from the overlaying bridge that we will place later. A good basic rule, because you think how many implants should I place? Let's say that every implant can carry approximately 1.5 tooth above later on. So 5 implants, that means 7.5 teeth, or maybe up to 10 teeth even. In the upper, we want to go a little bit longer, so we are up to 9 here, and that is good. About 10 teeth in the upper and 10 teeth in the lower, and that is approximately what we do most of the times. Also, we see the angles again, vertical to the bone, so they can receive the forces in a straight line. So let me show you this. We have the same picture again. Here we have only 4 implants trying to cover the same area, and when we place them angulated, there can be other problems. So this is also a solution, very nice and straight, but maybe too many. 1 implant per tooth, very nice, very nature-like, but maybe too much, because here we have other problems like hygiene, of course cost might be a factor, but let's don't talk about that here, and also the nourishment of the bone between the implants. Are they coming too close together? When we look at the lower picture, we can see that actually these two areas look quite tight. The other ones, they look okay, so that could work anyway. And this is actually a case that has been followed up several years, so it works nice. This is a very good surgeon. So,
but again, it's interesting that there's such variety in how it's practiced. I mean, you don't have to be a dental professional to see the difference here. I don't guess, but I guess both ways of doing this. These are kind of the extremes for restoring almost full jaws. But both can be successful and both can have their issues. I think that's kind of the takeaway.
Yes. When we talked about hygiene, we can look at this as well. For example, placing 6 implants in the upper, it doesn't mean that you have to place them with exactly 1.8 centimeter between and distributing them exactly. It could be placed like 3 in one side, 3 in the other side, so you actually leave out this difficult area in the front. This is the most difficult area for implant or bridge users, because here you make the sounds when you talk, when you eat. There can be saliva seeping through, so you actually spit when you're talking and eating. And if you can leave this area free from implants, from interference, and actually let the two pontics touch the gingiva perfectly, then you give the patient a nice confident smile. There's no problems with speech and with eating as well. Mm-hmm. So this is a very nice technique to give this area a better care. Again, on the lateral side, we see that 3 implants doesn't have to be placed in the middle. We follow the teeth and we actually leave one out instead of placing number 4, which could jeopardize the whole construction. We leave this empty, so there is room for hygiene as well.
This could basically be with the solution to one of the previous 2D bite wing X-rays we saw, where there was 3 implants placed very, very close together. Maybe 2 has in position relative to the teeth, and then making a bridge construction with the pontic instead could have been something to consider ahead of surgery.
Yes, knowing the fact, but now when we saw the pictures, of course, we should have considered that.
It's always easy to say afterwards.
But also thinking that way, thinking hygiene. Yeah. How should the patient take care of the bridge afterwards? That is also something that we can contribute also already in the planning step. To see, is this a hygienical bridge, or is this as many implants as possible bridge? Mm-hmm. So let's start think hygienical maybe, because it helps the bridge to survive for a longer time.
That makes sense.
We talked a little bit about angulated implants, and we can see that of course these can cover and take the forces in some way, but an angle with the forces coming from the top actually gives stress to one of the sides of the implants. It's just easy and simple biomechanicals. So when we look, for example here, trying to place the implants where it's possible, because without the guide and planning, you don't dare to go close to the nerve, so you stay safe. You place everything between the foramina, and instead of that, you actually place a long cantilever. This means, of course, that the forces when the patient bites in the back will stress the construction first in the middle, because it's a metal bar, so the whole construction will be stressed, but also the implants. So if you let me zoom in here and we watch this detail, we can see that the bone level already is not where it should be, but actually creeping down on every side of the bridge. Due to forces, what is happening down here, we don't know yet. We cannot see this on these X-rays. And if there is mobility, this will go very, very fast to actually extract the bridge in one piece. So look out for and think hygiene. Make it easy for the patient to clean. Think about the angles, straight angles or straight lines and vertical positioning gives the implant a good future or a good way to absorb the forces. And try not to make too long cantilevers. Instead, place one implant in one side and leave out a pontic in the middle or an implant in the middle for a pontic so you can reach it for good hygiene instead. So we have now seen several considerations what you should think about when planning for implants, when placing implants. These considerations, they are the same for freehand placing or for planning like with the implant studio. So there is no difference. I wanted to show you as well all these different variations inside implant studio, but we have already been talking like 45 minutes, so I think this is a good way to say that this was the first part of basic considerations, and the next part we could actually do all these placements and look how they work inside Implant Studio, so I may show the tools and how we can work with them in a daily basis.
Yeah, I think that would be an awesome awesome bridge for our next Inside Implant Studio webinar, because that will really give us, okay, so the impression I'm taking away from this webinar is that placing implants, I need to consider so many things. I need my hygienic considerations, I need my prosthetic considerations, I need some component specific considerations on the implants, I need some biomechanical considerations, I need some aesthetic, all the normal, you can say, dental things that we consider, of course, always goes into it. So there's so many variables, and it really, what it boils down to is how do we build up a routine and a practice for ourselves, and definitely using the digital tools and using better implant planning softwares that is, you know, taking in more information from CBCT scanners and intraoral scans is definitely a way to have a way of building this routine, and even though you have the routine, then it's a way of improving your existing skills. So I think that's definitely a follow-up or call to action to everybody out there that we're going to make a follow-up webinar on seeing this live in the software.
Very good. To summarize today's webinar, I think we can be sure about or unified in the things that we should actually ask the surgeon about his preferences. We have some questions today about which surgical kit they use and so on. So again, take this webinar to your surgeon, sit down and talk about these things, which implant system they prefer, why they prefer it, which implant kit you are using and so on, because inside Implant Studio, when you choose the implant, you can already choose if do you want to use just a drill guide or a full guided surgical guide where you actually can place the implant through the guide as well, so you get the right height and depth position. Again, try to maybe make a copy of your recent planning and suggest another plan, so you can show two different versions of the same planning of the same case, so the surgeon can choose which one he actually prefers. And final, but very, very important, remember that the responsibility for the placement of the implants is the surgeon's, so get the approval from the surgeon before you print the surgical guides, so you don't do any work in vain. So we have some questions.
Yeah, so I think this was what we had in plan for the schedule. So we have some questions that we wanna cover as well, that has been coming in from some of the listeners here. The first one is related to Implant Studio and the reports that we output. It's a question asking when will the surgical drill sequence of the actual surgical kits from different manufacturers be available in Implant Studio. And the question can be answered with the first kits will be launched with full drill sequences with the 16.2 version of Implant Studio that I promise you here today will be available before Christmas. So an early Christmas present, and there we will include the full descriptions when we launch of BioHorizons, all of their guided drill sequences, and Straumann as well. And then we will gradually be launching more and more over the following months. It doesn't require you to update your software, just requires you to update your implant libraries when you're prompted that there's updates. Mm-hmm. Then there's a question on the sleeves that are available in Implant Studio, if we will have OEM sleeves and third-party sleeves or one over the other. So the way it works today is that all the implant companies basically decide on what components they want in our software. So many of the companies who have their own fully guided solutions, they also have their sleeves, and we have them available. There are exceptions to that. For those exceptions, for most of them, we do have third-party sleeves available from different third-party manufacturers. And then there's a question in general on library updates. The way it works is that we work together with all these implant companies on making the libraries available to our users. Whenever we have an update or the implant company has an update, they inform us, and then we collaborate with them to incorporate the update, and then we release the library on a server that can then be downloaded from the software. So it's not like it is with Dental System where you are distributing files manually. Here we control everything, and you can access everything from the software itself, which is very nice. Then there's a question on CBCT files and 3Shape Communicate, if that can be transferred via Communicate, just like a Triascan. And here the short answer is right now it cannot. It will not go through. So if you have a case in Implant Studio that includes a CT scan and you send it via 3Shape Communicate, then the receiving end will not receive the CT scan, but he can receive the entire case, and he can manually then go in and load the CT scan if it's transferred to him somehow else. This is something we're working on to of course support full case transfer of this via Communicate, but it's not available yet. Then there is a question on how can a lab technician know about what surgical kits a given surgeon will use with Implant Studio guides. I think, Jan, you mentioned a little bit that it's important that if the lab is involved in this, that you talk about these things, because if the surgeon places an implant with a given sleeve in there, maybe he did it by accident, maybe he put the sleeve in there by accident, you know, he didn't think that he was supposed to decide on a given sleeve, and ultimately you can say the sleeve actually decides on what options you have for the surgical kit that he's going to use. So I think talking together here is key, or communication is key between the different parties, and definitely making sure that you're on the same page, I would say, is key.
We have a question about next webinar and when we have plans for that. First, I would like to recommend all the previous webinars that we have in this Implant Studio, Inside Implant Studio series, that you can watch either from our website or on YouTube. Just click, go to youtube.com/3shape, and there you find Implant Studio, and you can see and recall all the webinars that we had on Implant Studio, and also the others from 3Shape, of course. So if you have any questions, or if you wanted to see more Implant Studio software today, for example, then I can recommend you to go to YouTube and to watch the cases there. Also on our previous webinars, we had some links to cases that we had presented, cases that we worked with on the webinars, so you can go and download them, so you can actually try them out yourself and start doing surgical guides by yourself. We have a question about recommendation for 3D printers, Thomas.
Yeah, so 3D printers, I guess that's of course when we talk about guides and guided surgery, that's of course a link into the workflow, and what we're seeing at the moment is of course a lot of things happening and a lot of buzz, I would say, about 3D printing, but there's no doubt that it's here for good now in dental. I think that's safe to say. Recommendation, the way it works today with Implant Studio is that we have you can say established integration with some 3D printers in there, and we are of course working on expanding that integration. And to mention a few, then the integration today consists of printers from different manufacturers, so that is both EnvisionTech, Stratasys, EOS, and many others that I can't just name drop because it's too long since I've seen the list. Obviously, one of the things that we are seeing is that some of the smaller 3D printers are really starting to pick up, which is very exciting, especially for implant dentistry and guided surgery. And here we see many different brands out there really starting to come with both some very low price printers with the right material properties, which is very important when we talk about 3D printing for surgical guides, because we need to have materials with good stability. We need the printer to print with high accuracy, and we also need the materials to be biocompatible on a short-term scale. So any printer that kind of fulfills that three basic requirements is what we're seeing coming more and more often into the market.
As we are coming closer to Christmas, this was the last webinar before Christmas, but of course we would like to continue this series in the new year 2017, and we will get back to you all with dates for the full year and some what items we are going to talk about as well over the following year. So stay close to your mailbox and also watch the Implant Studio webinar link on our homepage where you can follow and sign up just like you did for this webinar to get online and to listen to us again maybe in January or February. We have the last question of today. What do I need to start working with Implant Studio? As a dentist, when I'm sitting here in my clinic or as a lab, I'm thinking, okay, this webinar was nice. What do I need? I want to get on board with this. Where can I go and who can I talk to?
Well, where you can go and who to talk to, then again, a lot of information can be found online and you can also sign up to be contacted by someone locally in your country by going to 3shape.com and then go and subscribe for us reaching out to you. What you need depends on your existing system and what you're looking for, you can say. But Implant Studio is a software that comes in different configurations, so you can really configure it to your need. If you're in the dental practice or if you're in the dental lab, then your needs might be a little bit different. And of course, if you're already working with 3Shape, then you can say Implant Studio is an add-on to the ecosystem and the environment that you already know. If you're new to 3Shape, then Implant Studio is an open system. So again, there you have possibilities of integrating it in many different ways into your business.
Very good. And in your chat function, you can see and find a link to our homepage where we actually present the webinars, the previous ones and also the upcoming ones. So just go in and click the link and it will show us this page. I'm just opening it up. So now you can see it. We have webinars. We have the different webinars, and we can actually also follow the different areas of interest. For example, from trios or implant studio, ortho, dental system, and so on. So please go ahead and find your favorite there. And for today, there is only one page left in my presentation, so let's see if we can find it. Not the YouTube one, sorry about that. Let's try it again. I click here instead, and this is the one. It's soon Christmas, so we would like to take the opportunity to wish you all a Merry Christmas and a good ending to the year. And as you see on the presents in the card, there is a card. There is the X1, coming up in March, and there is a lab scanner and the trios. But where is the Implant Studio software? We need to get this in there. Yeah.
Well,
maybe Santa Claus is holding it in the other hand or something.
Yeah, maybe it's because it's a software.
Yes.
It doesn't do that good underneath the Christmas tree. I don't know.
You're right. Yeah.
But yeah, I think watch out for the announcements on the next series of webinars that will be starting early next year. And one of the things we want to follow up on is this webinar and taking it into the software and see how this plays out in there.
Finally, as again Christmas is close, I would like to take the opportunity to ask for your wish. What do you wish us to do a webinar on? Do you have a special interest, a part of Implant Studio that you want us to focus more on? Please write either in a mail or in the chat room here, or just a mail back to where you signed up for this webinar, and we will try to see if it's possible for us to make it happen in the future. So thank you, Thomas,
thank you
for
for
today.
having me in.
And thank you everybody for listening, and Happy New Year and a Merry Christmas. Goodbye.